Yes, thank you all so much for joining us for the second installment of this weekly webinar series. Rebuilding Alliance has had a long commitment to medical access. We've been providing up to 80,000 meals a day in Gaza in partnership with the World Food Program, and medical access has been at the core of our advocacy since February. We are honored to host this group of distinguished speakers to share their updates and insights on the critical issue of addressing polio and the potential for a polio outbreak in Gaza. We have Dr. Irfan Akbar, the WHO's polio country support team leader. He will discuss the current status of the vaccine rollout plan and explain what a polio pause is and why it's necessary. We also have Dr. John Kahler, a pediatrician and the co-founder of MedGlobal. He will describe the status of children in Gaza and MedGlobal's role in the vaccine rollout. We have Dr. Mobeen Rathore, Chief of Pediatric Infectious Diseases and Immunology at the University of Florida College of Medicine, Jacksonville. He's going to talk about the realities of polio, what we know about the polio virus in Gaza, and describe the epidemiological likelihood of mass spread of polio and the need for vaccination in Gaza for everyone. And we also have Dr. Jeff Goldhagen, president of the International Society for Social Pediatrics and Child Health. He will discuss the important role that physicians, pediatricians, and child health professionals can play in addressing these types of global challenges to child health. I want to hand it over to Donna Baranski-Walker, the founder and executive director of Rebuilding Alliance. And thank you all so much for being here and for all the important work that you do. Donna?
You, everyone. Really honored to bring this forum together and to have this moment to delve deeper into such an important response. Being able to look polio in the eye and stop it here in Gaza. If all goes well, this is what the World Health Organization, UNICEF, and so many NGOs will be doing, along with really people on the ground more than anything else, in rolling out a vaccine program that can bring the world together, but more importantly, stop the polio from taking hold, stop an outbreak, and protect the world. I'm really Rebuilding Alliance has been working inside of Gaza for 21 years now. It's been something we began in the hope that we would be helping families rebuild homes that was desperately needed then and all the more desperately needed now. Our efforts now extend to serving food. We were good at this, came to be part of being able to deliver hot meals long before this crisis. But in the crisis, our meals went from 4,000 a day to now over 55, 60, 80,000 a day sometimes. And we're doing this from 30 kitchens. And we were hoping that our program manager would be speaking to you today because food is also part of the health equation. Instead, he's evacuating. Our kitchens are often evacuating, where we work in partnership with the World Food Program, supplying, and that's how those numbers can be achieved because of the commodities that are brought in through the World Food Program's entry. That commodity level has been going down. The foods that we're able to serve have been dwindling. And it's serious enough. It's certainly serious that every aspect of, or just every part of your advocacy, everyone who's on the call, make sure that you're always asking for food and humanitarian supplies. It's supplies that extend all the way to just simple things like soap that's being restricted in entry. We are really honored to be partnering with the International Society for Social Pediatrics and Child Health on this campaign about polio. It's got to be the role of doctors It is it is the word of doctors and the role of doctors that can guide this effort and extend beyond boundaries to provide safety. Polio is just, as you'll hear in our webinar, is just one part of an immense tragedy that it has to be addressed. Maybe this is what brings everyone together to be able to make that happen. With that, let me go ahead and ask Dr. Jeff Goldhagen to bring forward his thoughts, and then we can go to our guest speaker from the World Health Organization. Go ahead, Dr. Jeff.
Yeah, Donna, thank you, and thank you for all the tremendous work that you're doing in the current situation in Gaza and over the last 20 years. I'm going to be uncharacteristically short here. The realities that we're facing globally for children are grave. As we speak, tens of thousands of children in Gaza are being killed and wounded, and in both Gaza and Israel, the impact of this war is having an increasingly devastating impact on the psychological status of children that will last throughout their lives. In Sudan, we have millions of children who are dying and being displaced. We know that 20% of the world's children, which means well over 500 million children, are impacted by armed conflict. Tens of millions are currently displaced and wandering the world, both cross borders and inside borders. We have Ukraine, Yemen, Syria, the Congo, Myanmar, and so many other places around the world that are wreaking havoc on children. And if we look back historically, yes, we've made huge strides over the last 30 or 40 years in addressing many of the critical health issues of children. We've worked through oral hydration campaigns, treatment of pneumonia, kangaroo care, maternity care. And if you look at the SDGs, we've made really significant progress. But our understanding now is that there are far greater existential threats to children that are confronting us. Armed conflict certainly being one of them, climate change, globalization, and other critical issues that are threatening children, both in low and middle income countries as well as high income countries as well. So the question has become increasingly cogent. We know what our role has been in addressing critical global issues relating to children. But what is the role of pediatricians, child health professionals, physicians in general, as it relates to addressing these global existential threats to children? And so one of the foci of this webinar today is to really ask that question, and by learning about what's happening on the ground in Gaza and really beginning to understand what polio means for Gaza and the rest of the world, and by hearing from our colleagues, particularly MedGlobal and Rebuilding Alliance from the nonprofit sector, to really begin to get an understanding as to the critical role that we can play as physicians, and in particular child health professionals, as it relates to addressing these global issues. And so it's really an honor to be able to participate in collaboration with MedGlobal, with Rebuilding Alliance, and with a host of other organizations, both in the public and private sector, that are responding to Gaza and the catastrophe that has unfolded there. So, and so as we move forward, let me just take a moment for a shameless advertisement to encourage you to join the International Society for Social Pediatrics and Child Health, which is ISSOP. We're the only global organization focused specifically on these global social and environmental challenges confronting children. We need your knowledge, we need your experience, we need your expertise. If you can join us at issop.org, we would really appreciate that. And let me finish by again thanking all those organizations and individuals who have made the commitment, risked their lives to care for the folks in Gaza and in particular children. And so with that, let me turn it over to Dr. Akbar, who will provide insights as to what will unfold as with respect to the polio vaccine campaign. And Dr. Akbar, thank you for taking the time to be with us.
Thank you, Dr. Jeff, and thank you, Donna, for the invitation. I think last call Dr. Hamid attended, so I don't know what is already being shared, but maybe just to give you a little bit context is that we have 6 polio virus variant which were detected in Khan Yunis and Derbala. And these samples were collected on 25th of June. These were environmental samples and which came positive. All 6 polio viruses are genetically linked with the CUDP2 that was circulating in North Sinai in Egypt, where it has not been detected since December 2023. Now, in terms of the risks that probably we can share with you is that polio does not consider boundaries, and it transmits from one area to other very quickly. So the risk assessment which was conducted by WHO and UNICEF and health authorities on 29th of July, it confirmed a high risk for further spread in Gaza and internationally. So the immediate risk is to the neighboring countries, which includes West Bank, which is part of OPT, but I mean it's still it has an increased risk. Israel is also at risk, but in addition to that, Egypt, Jordan, Lebanon, Syria, and Iraq are also at risk. Essentially, what we do is that in this kind of a situation, we need to have a proper outbreak response. And for essential outbreak response, there are some prerequisites. We need to respond to this outbreak with at least 2 large-scale mass vaccination, high-quality polio vaccination campaigns, which needs to be implemented within 1 month of its beginning. And we need to target all the epidemiologically linked area. For this response, what we have been planning is to go up to 10 years because of the low immunity amongst the children after the switch of TOPV in April 2016. For the vaccine of choice is the novel oral polio vaccine type 2, which would be used in this campaign. Now, for achieving high quality vaccination campaign, we need to vaccinate all children in a short time, within days. Already what we see now is that the response is a bit late because this virus was not isolated for almost 6 or 7 months. If we see into the genetic sequencing, probably we feel that this virus went into Gaza maybe late last year. So we are already late on that. And the other compromise is that because of the security situation, probably we will not be able to do a house-to-house campaign, which is ideal for this situation. Having said this, we need to ensure that we reach up to 90% coverage, and which is assessed independently as well. The preferred modality has to be house to house, but in this case we are not going with that because of the certain security situation. Now, if I just give you quickly some target, the under 10 target in Gaza right now is 640,000 children. The planning that we are doing is a 5 days campaign and 2 days of catch up. But just before coming to this call, we had a call with COGAT, and it seems that probably this 5 plus 2 days would not be agreeable to the authorities, and probably we have to change and do the campaign in lesser number of days. So, I mean, the planning and the actual execution probably would be different. In terms of the rationale that what we have been raising with the authorities is that we need to have one campaign simultaneously all over Gaza, which is still under discussion. Why we are saying this is because of the epidemiological rationale, which there is what we talk about is the pulse vaccination with oral polio vaccine, which creates a strong barrier or wall of intestinal and mucosal immunity to community transmission of poliovirus. And if coverage is not optimal of this campaign, and if it is staggered over time or geography, gaps will remain in population immunity, which will allow outbreak to continue. The other operational rationale is the vaccination campaign implemented over a prolonged period or staggered geographically results in many missed children due to frequent population movements. In a prolonged campaign, microplans become less accurate as availability of health workers, security, cold chain, and overall operational feasibility change in conflict setting. Now, there are other rationales which I would probably not go into, but maybe just to give you a quick update on what is the situation right now. So, what we are all working is that the campaign dates were changed. Initially, it was planned on 15th of August, then it was changed to 25th, and now the date is 31st of August. This is because of the vaccine supplies and the cold chain equipment, which probably now will reach on 25th of August to Gaza. So we will be able to conduct the campaign if all other things go well. Yeah, and probably the issues which I can mention here is that, as I a little bit alluded to, is that we are still in negotiation is to actually agree on the areas that what we are saying from the UN side is that we have to go for all areas and not have a staggered campaign, but there is still a discussion from authorities because of the security situation. They want it to be staggered. For us, the other important area is the humanitarian pause. The best way is ceasefire, but I think ceasefire right now probably may not be possible. So the other options that we have put on table is that humanitarian pauses at least should be ensured. In the humanitarian pauses for some days, which will allow our vaccination teams to actually go out and vaccinate children and without a fear of any strike or any and also we don't want to have some people losing their life during this campaign. So for us, humanitarian pause is very much important, and what we are requesting all parties, whoever can support this, that would be really important for the polio vaccination campaign's success. For us, if we don't reach to what we have put on table for this 5+2 days of campaign, we can look into some other contingencies. But any contingency beyond this, like 5 days of campaign activities and then 2 days of mop-up, we will be compromising on the quality. And what we feel is that probably will not be able to stop this transmission, and maybe it will go on for a longer period of time. Probably this is all which I can share with you as an update and what we are doing right now. But maybe I can give any answers if there are questions, which will also help me if still there are some questions which colleagues can ask. I'll try to answer to the best of my knowledge. Back to you.
So, Dr. Irfan, I want to ask you, can you tell us a little bit more? I know you've explained the 5+2 days, but I really believe that it's important. We as people throughout the world can help press forward. Why is 5+2 important? What happens? What happens in the 5 side of it? What happens in the 2? Tell us, give us some examples of what you expect this rollout would look like. And this is what this is what you need. Tell us what it means in more detail, and we'll be able to pick that up and bring that forward with our elected representatives even.
Yeah, thank you for this question. Actually, as I said, that the ideal campaign is 3 days. Sorry, house-to-house campaign. And for house-to-house campaign in majority of the globe, and even in our region of Emro, we do the house-to-house campaign in 3 days, and then we have 2 days of catch-up. So in 3 days, we try to reach all the children to their house, to their doorstep, and we vaccinate them. And if you have any missed children, so the next 2 days are used to reach out to those missed children, which is some we record and some which are not recordable. But then we search for the missed children and check areas if they are missed. So then we go again to those areas and cover them. Now, as I said in the beginning, that we are not able to implement house-to-house campaign, and it would be fixed site strategy in the health facilities and outreach. So we need to give more days for the families to come to actually to these vaccination sites. It needs more social mobilization activities. It needs like for the community to know that there is a vaccination site where the kids would be vaccinated, and for them to give the opportunity to bring their children to these health facilities and vaccination sites. So we need at least 5 days. The micro plan is devised in a way that we feel that if we go for 5 days, that will give us ample time for the communities to reach out to these facilities and vaccinate their kids. With this, we feel that probably we will reach up to 90% coverage, which is, I think, the minimum that is required. But if even something went wrong in this, probably we will not reach to the 90% mark, and with this, maybe we will not be able to stop the transmission. So that's why this plan was made. Like as I said, it was already a compromise plan. But if even we go below this, so there is a fear that probably we will not be able to achieve what is required to get to stop this transmission. I hope this clarifies.
And you'll be doing this throughout all of Gaza. So not only the highly populated humanitarian zones, but also into the north, into people stayed, and we have our kitchens even in the north. That their population is spread out. So you would be part of it is to actually get the vaccine to the centers and the distribution areas, and make sure that you're covering all of the area, all of the land in every governorate and every location.
Yes, you are right. The plan is to cover the whole population at the same time. I mean, if we cover north at one point and south at another point, so then we are giving chance for the virus to, to still continue, and also the chances of missed children are higher because there is frequent population movement. So if we vaccinate at 1.1 area, so people may move from those areas, or maybe the other area is not vaccinated. People may move to the areas which is already vaccinated, and we don't know how many kids are now shifted there. So it creates a lot of problems. So the population movement, and because of this virus, that we have to create this pulse, as I said, pulse vaccination, that we have to cover the whole population in a short period of time. We cannot, afford actually to have a staggered campaign which will allow the virus to still continue.
Yeah, this is Jeff. We have some questions in the Q&A as that's specifically related to vaccine and the virus, and Mobeen Rathore can answer those. We do have a question though specifically about COGAT and your conversations with them, and then you mentioned that that support from global support to implement this would be important, in particular from pediatricians. Who would you say that we need to be reaching out to help support this effort?
I think right now the forum for UN to talk to the Israeli government is the COGAT, which is kind of the link between the two. And the requests are put forward to COGAT, and then they discuss internally, and then they come back. So I think U.S. government is one party which probably can really help to influence some of the decisions in the internally, which they discuss, and then they decide. So maybe U.S. government could be one. I don't know who in the U.S. government, but probably Secretary of State is already visiting Israel. So maybe that can be one source that some political leverage or political pressure could be put on the Israeli authorities, because the risk is not only to the people living in Gaza. The risk is also to the children in Israel. So maybe that is what I can think of, but other colleagues can comment that who could be the best way to advocate this for.
And there's a question if you can speak to the viability of a ring vaccination campaign, both in relationship to polio, but also with regards to present situation in Gaza.
Sorry, I did not get the question.
Well, the question is about a ring vaccination campaign, a different form of vaccination campaign. And then the other question that relates to that, what about vaccinating for other infectious diseases at the same time? Is that feasible?
Yeah, I think right now, I think what some of our partners are also of this opinion, and we agree to it, that only polio vaccination may not be very much welcomed by the community there. So there needs to be integration with the other antigen, and also maybe some other supplies for operationalization of this. It takes a lot of effort. The country team also said that maybe the first campaign should be used as to understand that what additions can be made to the polio response, and then understand it well, and maybe go to the community with these additions. At the same time, I think for the first campaign response, soaps would be added, as UNICEF is probably is going to help with that. Since it's a fixed site strategy, so soaps and other pluses could be added, and we are very much open to add other services if they are available. I think one plan was also maybe to, in the second round, if feasible, to add hepatitis A vaccination, because there are a lot of hepatitis A cases right now, as we know from the information coming out of Gaza. I hope this answers the question.
That's great.
We've got a question from Don Clancy at Pass Blue, a reporter, and she's asking, indeed, was it correct that they didn't agree to a 7 days for the pause? And then the alternative, what does that alternative look like? And can you confirm whether the WHO supplied polio vaccines? Have the vaccines crossed the border into Gaza already? And if not, where are they?
Yeah, on the first one, I think I cannot say right now that they did not agree. Still, the discussion is on, and maybe we in a few days' time we will be able to say that what is finally agreed. Today there was discussion again, as I said earlier, on the vaccines. What UNICEF told us, because UNICEF is dealing with these vaccine supplies. So this will cross over into Gaza on 25th of August. They are being shipped right now. First, they will reach to Tel Aviv and also the cold chain supplies, and then it will be transported to Gaza. And the date right now is 25th of August when it will reach to Gaza, which will give us some time to prepare for the campaign and do the campaign.
Thank you. And we had a question that has come up in the past. Can you tell us where the vaccines were manufactured? What's the manufacture date? We've heard some rumor or concern from community about the quality of the vaccine, and I think your assurance will go a long way to resolving that.
No, I think, the NOP2, these are vaccines which are manufactured in Indonesia, and whatever vaccines are produced, they are pre-qualified from WHO, and there is a stringent method which is being followed. Just to maybe note that we had some shortage of supplies because of these processes were being completed. So just recently, we had some shortage of supplies for NOP2 vaccine, which is the vaccine of choice for CVDP2 outbreak. So these are pre-qualified vaccine of WHO, and the quality assurance is being done. There is nothing wrong with the vaccines. I hope this clears.
Much appreciated. Let's go on to another question. Jeff, are you ready with yours?
Yeah, so there's a question related to the previous vaccination coverage, that 90+% of people were vaccinated prior to October. And so can you comment on that? If there was such a high vaccine coverage, why are we so concerned now?
Yeah, actually, the two things. One is that the vaccine coverage, even in Gaza, was very high, as you mentioned, but it has dropped in the recent times. The recent, in 2024, what we have right now, it has dropped to 87% coverage of the routine immunization. Plus, in routine immunization, there are two antigens being used. One IPV, which gives protection for type 2 viruses, which is the CVDP2. But this is individual immunity. The mucosal immunity, which is required, that is not provided by IPV. For that, you need OPV, oral polio vaccine. And the oral polio vaccine, which is under use, is BOPV, which does not have type 2 antigen. So for this outbreaks, if you want to stop the outbreaks, we have to use oral polio vaccine, and the vaccine of choice is NOP2, which is genetically more stable in comparison to the type 2 vaccine, which were in use almost a year ago. So for stopping the transmission, oral polio vaccine is required. IPV can give you individual immunity, but it cannot stop the transmission because gut immunity is not there. I hope
And
this.
the reality for children is that the vaccine's given at 2, 4, and 6 months, and then not again until 4 to 5 years. So children themselves, regardless of what the previous vaccination rate was, those children, in particular under 5 to 6 to 7, are either unvaccinated or undervaccinated.
Jeff, if I may add, there are
Sure.
also about 50,000 newborns who have not been vaccinated. So that's a huge risk factor right there. As we know that they are not only are they at risk for polio, but all the other vaccine preventable diseases. So that adds to the challenge.
Right. Well, I think that's pretty much most of the.
Jeff, there was one question thing that if I may answer, right? I put the answer in the chat also. This question about risk of polio from the oral vaccine, and the risk is very low and rare. It's 1.3 cases in one study, and I'm going by memory, so please excuse me if I'm wrong. 1.3 cases per year in 26 countries, and the CDC estimates the risk is about 1 case in 2.4 million doses of OPV administered. So the risk is very low. The benefits way out risk, as Dr. Akbar has eloquently stated, why we need the oral polio vaccine.
Great. All right. Well, I think that's pretty much most of the questions. Mobeen can answer some others more specific to the as he has just now. Dr. Akbar, so ultimately, end of the day, whatever support, whatever we as certainly as a global community of pediatricians and child health professionals can help support you both from an advocacy standpoint or whatever ways, we really stand ready and prepared to do so, and to thank you and others who are making this happen, and UNICEF and WHO. And one of the questions was, where are these vaccines going to be actually administered? And so if you can comment briefly on that, because part of the answer is in collaboration with other organizations that are also on the ground, in particular the feeding sites for Rebuilding Alliance.
Yeah, I think as I said, this would be a fixed site strategy. So on the ground, we have WHO, UNICEF, UNRWA, and MFINET who are helping with this, and of course your organization is also helping. And the macro planning is done in a way that we can cover the population with all these different health facilities and different fixed sites, where community can easily come to these sites and vaccinate their kids. I can be maybe if I get more information from the country team, I may be able to tell you that where we can or where we have involved your organization in delivering these vaccines at the field level. Maybe I can get some more details from the country team.
Much appreciated. We'll all look forward to that. And we're doing this series every week, so we'd like to have updates and bring you back in the future. I'm noticing a lot of people asking about the other routine vaccines. Will you be doing any other vaccines during this rollout for polio, or can you provide the full coverage of vaccines at this time?
Yeah, actually, WHO, UNICEF are working together with MOH on the continuation of routine immunization. I think the team in considering all the challenges that were there, I think what they have done is a great achievement. As I said, that the vaccination coverage has gone down, but even to reach to the number of children which the program is reaching right now, the routine immunization, that is commendable. And WHO, UNICEF, and all partners have their role in that. In a vaccination response, as I said, that this is a supplemental vaccination response. It's not going to change the routine immunization in any way. And for any kid who is due for routine immunization, he will get his or her dose for routine immunization. This is only a supplemental activity which is there for stopping polio outbreak. Otherwise, all the efforts for continuation of routine immunization are there and will continue.
Thank you. So we'll move on a bit now over to Dr. Kahler, and please tell us what you're seeing from a MedGlobal perspective. Also describe your role. I'm really glad to hear that MedGlobal will be participating in the vaccine rollout. Please.
Thank you very much, and thank you for the invitation. I'd like to Dr. Akbar's presentation was excellent. I certainly can't add anything to it. I would just like to add 2 points of clarification to it. One is that it won't be easy to get the kids to these sites. It may be easy if one thinks about it, but it's certainly not easy on the ground. People are moving from place to place daily, and fear is a driving force. And if you ask someone whether or not they would rather stay sheltered in what they consider to be a safe spot or come out to possibly get their child polio vaccine, I would venture to say most people are going to take safety there. So education and awareness, although very appropriate, probably takes second tier to the safety issues. This is why a verifiable and profound ceasefire is important before any of this begins. Second thing is that I would disagree around the ongoing Ministry of Health activities for routine vaccinations, because this is actually this is the ghost of Christmas future. Meaning nobody really knows what the post-ceasefire administrative structure is going to be, and whether or not they have any ideas about how this is going to happen, who's going to coordinate it and stuff like this. This is a different world. So this isn't going to be the post-world. This isn't going to be the pre-conflict world, just a little bit worse. Nobody knows what's going to happen here. So what's going to happen is completely unknown. We have 17 active medical access points, which for the discussion on the group, these are just very small clinics. And we will be active in all of those that are asked by the WHO. Currently, there's a consortium run through the run out of WHO that has about 17 different groups on there, and each group has 2 or 3 different participation sites. Currently, our 3 biggest ones are actively involved in the planning on this. Our new medical director and our ground team just did a needs assessment, and as you might imagine, the community staff feels unprepared and unaware for this type of a massive endeavor. Not inappropriate, because it hasn't happened in the Gaza Strip yet, and these folks are. I'm probably the oldest one on the call, and I've actually seen polio in the United States. So that's how far back I go. So I know most of the trainees are red book scared by it, and most of our folks have not been actually exposed to it. So we'll participate with all the sites that are asked. Currently, as I said, we have 3. The answer to your question is, what is the status of the children? I can give you a quick update, namely 100% of them are sick, either with some gastrointestinal illness or respiratory illness. Those that aren't acutely sick have had experience with those, and those who are in that group are either calorically deprived or actually malnourished, and literally 100% of them and their families. You can't view these children as separate entities. Of them and their families have been under stress now since 7 October. And if you're on the wall that long, you're going to start showing very, very significant problems. And I just want to bring up one other thing, which is, think of the paradox of having this crisis in a closed community no bigger than metropolitan Detroit. And yet we're still struggling to figure out how to get things in when they're sitting literally 100 yards outside the gates. So the political paradoxes here are beyond, are unimaginable. So this is historical silliness. And the question, one of the things that, who do we ask? Well, the DNC right now is in Chicago. And Bernie Sanders, God bless him, called for an immediate ceasefire, which was met with rousing cheers and stuff like that. And just like it has every other time he's done that, it will probably have exactly the same amount of heft, which is basically 0. So it's a depressing time. It's a depressing time both for us clinicians. I'm not an academic, and God knows we'll be quiet for the rest of this discussion. But from a standpoint of a political standpoint vis-a-vis these children, it is a disaster. If there are 2,000 patients in hospitals a day, well, that has gotten 95% of the coverage. That means there's 2 million patients that are affected by the public health system's collapse and the infrastructure collapse. So we can use this as a time to focus our focus on what's going to be the ongoing problem. I mean, we can build a hospital in 6 months if you bring in the tents. Rebuilding the collapsed infrastructure, re-giving dignity and agency to this population is going to take generations. So I'll be quiet now. Thank you very much.
This has to be, for all the reasons you've mentioned, it's the time when our hope is placed, frankly, in the World Health and UNICEF and your efforts to roll out this vaccine. I think the whole world will hope that the pause for polio can be a lasting pause to be able to begin to address all of those things. But use this, make this open is the key. And
God forbid that cholera comes in. Or some pernicious pneumococcus comes in, because then deaths will start mounting in a day.
What are your team seeing in terms of health on the ground for children, especially? What are you seeing in the clinics?
Acute minor illness. I mean, acute ongoing minor illnesses, the same respiratory diseases you get from illnesses of congestion, illnesses of poor hygiene. When I was there in January, when I was there in March, 100% of kids had diarrhea, literally. And all the kids under 1 year of age had significant diaper rashes. And as a senior clinician, I thought, well, this is in my ballpark. I'll be able to deal with this, except every single solitary thing I would have told a mother in the south side of Chicago. They had no clean water, no new Pampers, no ability to do any of that. So 100% of them have bad illness. I mean, have illnesses, and not much you can do.
Right. Mobeen, and John, we'll come back to you in a minute. Mobeen, do you have anything to add related to the polio itself and risk for spread and potential risk to spread to Europe and the US as well?
So I mean, I think probably I'm as old as John, but I've not seen the polio in the United States. But I have going to medical school in Pakistan and spending my early years in Pakistan. I have seen polio, and I have friends who had polio. So it's a devastating disease. It's spread mainly through fecal oral, which is a great problem in Gaza right now, and it's a highly infectious virus. And it can really invade the nervous system. It can cause irreversible paralysis and even death. I think we don't think of that in those terms. And it is particularly dangerous in Gaza right now, where the malnutrition rates and toxic stress levels are so high. And as we all know, those two things make children more vulnerable to infection and the disease that comes with that. And children under 5 years of age are the most likely to have these viral illnesses, and especially infants under 2, which are many of those 50,000 are going to be under 2. This normal vaccination that has already been disrupted is a huge problem. And the reemergence of polio it's yet another reminder that the threat to the children in Gaza Strip, but also don't forget to the neighboring countries and beyond, stays. And this conflict, this war, is going to affect others who are not in Gaza. Nearly half of Gaza's population, or I think it's 2.3 million of the population, is under the age of 18. And 15% of these children are under the age of 5. And I already mentioned that about the babies who were born since the conflict started. And polio, has been eliminated from Gaza for more than 2 decades. That's the irony of it. For 2 decades, there was no polio in Gaza. And somebody in the chat asked, the immunization rates were actually 99%. Much better than we have in the United States, believe it or not. So the Ministry of Health there did a terrific job. And as Dr. Akbar said, those rates have fallen down to almost 86%. And, and that's they're the kids who are going to be most affected by this. And the emergence of polio in Gaza, is a direct result of destruction of sanitation and water treatment facilities, infrastructure, coupled with the overcrowding, displacement. I mean, we know this. We know all people who know about disaster medicine know this. The crippled healthcare system, Dr. Kahler has so eloquently talked about that. Those diarrheal diseases, hepatitis A is rampant right now there. And of course, the extreme malnutrition, the famine that we have been hearing, that's only going to make this worse. And, not only the infection and the disease, but the recovery from that is going to be also very difficult. And so, all these things have created an environment that is really ripe for the spread of the virus in Gaza, and I said beyond. I think I have to mention Dr. Akbar did a great job. The vaccine has to reach, we know that at least 95% of the population to blunt and stop this spread of the polio infection. And this can happen in the war zone. And believe it or not, it has happened before. And Dr. Akbar can shed more light on that. This happened in 2001 when the United Nations negotiated with the Taliban and Northern Alliance to promote polio immunization at the time of in collaboration with Pakistan. And UNICEF had 35,000 healthcare workers and volunteers who worked in the country to reach 5.7 million children. So I think this is possible. Not only that, in 2013, this has happened in Syria, in the midst of the civil war, and the country experienced a polio outbreak, first of its kind there for 14, 15 years. And so we have done this before, and I think if there is will, we can do it again, and this is going to be extremely important. And I think it's important also for us to remember that this is the most germs are the most non-racist living organism on this earth. They don't care what your race is, what your ethnicity is, what country you belong to, what religion you are. It finds, as somebody said, I read this, they find their heaven in an unimmunized, vulnerable individual, kids or adults. Unfortunately, it's going to be kids mostly. And something that I think somebody said, Jeff, I think, said that when this spreads, don't forget, Dr. Akbar already told us it spreads in Jordan and Syria and Iraq and even Israel. In Israel, there are pockets of Orthodox Jewish communities that do not immunize their children. So they are at risk. There's also travel, if between the United States and Israel, or these communities of these individuals. And so the virus can spread from there. It's only one flight away to come to the United States. We already heard earlier last year what that virus was detected in the sewage and water system in New York City. So I think it's important that we understand that it seems far away, but it's only a 12-hour flight away, 14-hour flight away from us. I think I also want to mention one more thing, and Dr. Akbar he's the expert on this. It usually requires two campaigns. You go and you immunize everybody, and then you go once again and immunize everybody. That's not ring immunization, but if you recall, I think some of you may recall that when this outbreak occurred in Sinai, one of the reasons it initially failed is they only did one campaign. So we are going to not need one, but we're going to need two, and it's going to be extremely difficult because the mobility of the population, where they live, you can't put access outside their houses and saying that this has been, it's going to be really challenging. But I think this is something that we have to do. I think I want to end by what the Israeli Society for Infectious Diseases has highlighted, that that these have occurred in Ukraine, in Ethiopia, in Sudan, in Syria, in Yemen. And I'm going to read some of the things among other places. And their society members are calling for, this is the Israeli Society of Infectious Diseases. They are the most knowledgeable people about infectious diseases in Israel. And many of them are very knowledgeable in the world. I know many of them. I was a co-fellow with one of my friends who's there. So they are calling for an immediate ceasefire to facilitate a series of essential public health. I'm reading this now, including a widespread and rapid vaccination campaign in Gaza, intensive sewage monitoring, improved access to healthcare services, better hygienic and sanitary conditions, access to safe water, and establishment of health-defining conditions such as improved food security, shelter, housing, and rehabilitation medical services. The adverse childhood events that we all talk about in the social determinants of health. I'll stop there and happy to answer any questions.
Great.
Just a quick question, Dr. Mobeen, about the spread, the risk of it spreading. So how could it spread to neighboring areas? Can you describe what it might happen into Israel? What would happen to Jordan? How would it get to Lebanon, Syria?
Dr. Akbar is probably going to be a doctor. I keep on calling him Akbar. His name is Akbar. Dr. Akbar is, I've lived in the United States for 50 years almost, so I've changed my pronunciations also. It's a fecal oral spread. So somebody has the virus in their gut, and they may not have the obvious infection or disease, and they go somewhere else, and then it can spread from there. So the virus is carried, the human vector. Now, as I understand, there's no sharing of sanitary or water supplies between those countries right now, so that can go that way. So it has to be a human vector, and there is still transportation. Even don't forget, even those kids who have been evacuated for healthcare reasons, other reasons, they need to be immunized right away. And I think I'm going to actually, after this call, the Red Book scare. I was chuckling when Dr. Kahler said Red Book scare about polio. Having sat on the Red Book committee, I think that's people would love that. But I'm going to call them and say they need to release immediately the AAP saying any child who's being evacuated from Gaza needs to be immediately immunized. I think that's going to be critical.
And
That's a
it
great
also
point.
it can
The
also
answer to your
be-
question- The answer to your question also is that the soldiers will bring it back.
Yeah,
I mean,
Well, soldiers will bring it back to Israel. Yes.
The soldiers will bring it back to Israel, and that won't even be a question. I mean, it will be there. Whether, I understand that Orthodox don't serve in the military, but still the interactions will be there.
And it can spread via the aquifer as well.
Yeah.
That's true.
And-
That's the Israeli Society of Infectious Diseases also mentioned that. Now, don't forget that the even though I said it's a fecal oral, but the virus can also spread if from your boots, if you will, and if it gets into the
Right.
and that just brings that message forward. It's not just about vaccinating inside of Gaza. Of course, this is the core, and it'll be the safety net for the world. But everyone who isn't vaccinated, make sure your children are vaccinated. Catch up on this. Polio is if you're under vaccinated, catch up with your vaccinations, like worldwide, because we've learned the hard way that it can spread everywhere.
There are a couple questions. John and Dr. Akbar, has there been measles identified as yet? Has there been a measles outbreak as yet?
Well, interesting. There have been measles cases documented. Now, all of this is clinical, of course, because and again, it's the same discussion. Most young pediatricians call any red rash measles, but there have been senior people that have documented measles. The beauty of it, though, is that there hasn't been any significant outbreaks, which speaks to the general immunization level.
Great.
But John, before Dr. Akbar said, there's a reason for that also, because the immunization rate against measles was also very high in Gaza.
Yeah,
And
that's what I mean. That's
most
exactly.
most eligible children would have gotten the vaccine. However, those who are born during the conflict I think the EPI in Gaza is also 9 months. Dr. Akbar can correct me. Those kids are reaching 9 months of age now. So
there's no question about that. But remember that they did continue at least through April. Once Rafah was invaded, the MOH fell down. I mean, collapsed. But at least through April, the vaccines were being given out of the MOH. The MOH was destroyed, and the MOH at Rafah, where people were forced into, was destroyed in April, May.
Dr. Akbar has his hand up.
Yeah, thank you, Dr. Mobeen, and thank you, colleagues. I think just to add what Dr. Mobeen has really helped to touch upon different points. One point that I wanted to say is that yes, it can. We can talk to the authorities, and we have done that. I was working in Afghanistan. I was leading the team in Afghanistan just before coming to the regional office here, and I had several meetings with Taliban at that time. And when they were in opposition, we were able to talk to them and do our activities. Though they did not allow house-to-house campaign, but in majority parts of they were controlling almost 60% of the country at that time. So we were able to do side-to-side campaigns and most campaigns in majority of the area. So I think this could be negotiated. And in the example that Dr. Mubin gave, I think Congo is one other example. There has been during war situation, there has been humanitarian pauses in different countries, and which allowed the humanitarian partners to actually implement these activities and to stop these outbreaks. On the measles question, I think one thing which probably all of us needs to consider is that at least I can give a polio example. I am not very much aware of the other surveillance activities, but I think after the war, the surveillance activities have gone down, and we only came to know about this outbreak when the samples were collected by Israeli authorities themselves. I think now that when it came, and there was more focus, then now we have received 3 AFP cases, one of which the preliminary results are PV2. So I think when we are not getting any diseases, it does not mean that they are not there, but maybe the surveillance system is not working up to the mark. So we have to consider that as well. Just wanted to add this back to you.
Yeah, we have a question, Dr. Akbar, how the vaccine will be registered. But before you answer that, again, this is not theoretical. We did have cases of, or at least one case of paralytic polio in the United States in Rockland County in New York amongst the Orthodox community in 2022. And for every case, there are many-fold more people who are infected, but not symptomatic. So it's not theoretical that it can spread from Israel to the US and to other places. And the other comment is that in those war zones, conflict zones that you mentioned, for which there were and have been vaccine campaigns, there have been hundreds of children who have had paralytic polio in those war zones, whether it's Congo or Yemen or Syria, go down the list. So it's not theoretical. It does spread. Kids do get paralytic disease, and the US is not, and Europe, because there were cases in Europe as well, is not, in quote, immune from the polio virus. So this is not just an issue for Gaza and the surrounding countries. So Dr. Akbar, can you say how the vaccine will be registered for each individual child?
Yeah, I think for routine immunization, we do use the vaccination cards, and that is part of the record. And also there is a register. For mass vaccination campaigns, what we use is the tally sheets. The frontline workers who are delivering the vaccine, so they use tally sheets, and in those tally sheets, the number of kids who are vaccinated according to their age, if they are below 1 year and above 1 year, up to 5 years or up to 10 years, they are registered in the tally sheet, not by name but by numbers. But if there are missed children, then those are registered by name and address that where these missed children are, and then there is an effort to go back to those children and vaccinate them again when they are available. I hope this answers the question.
I might also add that in addition to the paper chart or the paper note you give to the families, you might want to take a picture of the vaccine giving on their cell phone. They all have cell phones. They can all be kept as notes. And it doesn't need anything more than a simple click onto the card when you hand it to them.
Can I come again? For polio vaccination, probably we'll not be giving any cards right now. We'll be just telling in the tally sheets. What we do is that we will be marking their left little finger, and that is done for monitoring purposes. Because after the campaign finishes, so we do a post-campaign monitoring, and even intra-campaign, when you want to be sure that the kid is vaccinated. So we check the finger mark, and that shows us that whether the kid is vaccinated for this round. I hope this answers.
Well, I'm going to, well, first again, thank everybody for the tremendous information and those folks that have participated. We're beyond an hour now. We really do want to hear what we can do. There's a question here: who should we contact? Rebuilding Alliance has been having multiple meetings with legislative aides to bring up the issue, highlight the issue, ask them to contact the State Department, contact the president, contact the State Department, and so on. So all of you can be involved with doing that. As far as we've been looking to identify hospitals that will take children who are potentially in the future going to be evacuated. So I'm going to ask Dr. Kahler and Donna and Dr. Akbar to comment on how can pediatric organizations help in this particular effort, but also in general as this war continues. And as has been mentioned before, I think, John, you mentioned, we don't know what's coming after, and so to be there to help support whatever comes after. So John, Donna, and Dr.
Sure, let me just say two things. First of all, for those pediatricians American pediatricians on the line, contact the American Academy of Pediatrics and demand a letter of ceasefire. Some people have been working on this for quite a while. This is not a medical issue.
Not successfully, I might add.
Not successfully,
Yes,
no.
I was going to say not very
Not successfully.
No,
And
please,
some
I
of
understand
us,
that. This is a political
they're the
issue.
wounds.
You're right. This is a political issue right now, and that the Academy hasn't come out with something more than a vanilla statement about that war is bad for children is a disgrace as far as I'm concerned. So contact the American Academy, contact your sub academies to do that. It's an exercise in futility to contact your representative, but it's all you have right now. And so
It's not an exercise in futility. I'm going to counter you on that one, but keep going.
All right, but the end of the sentence is, but it's necessary. We need to keep driving for a ceasefire, and we need more than a ceasefire. We need to keep driving to be at the table for whatever the administrative structure is afterwards. This is an important.
And who is we? Who is we needs to be at the table?
We meaning for this purposes, we meaning pediatric healthcare professionals and public health professionals. It took us 12 hours to get a statement out of the American Public Health Association around a ceasefire in November. So these are not going to be easy issues, even though those of us on this call think that we're in one silo, but I realize we're only in one silo.
I think if I may add for the Donna, just for the Academy, I think this is extremely important. You have to keep writing to them. You can emailing them. It's a membership driven organization. The more they hear from members about one thing or the other, they're going to do that. That's our membership. I hate to say that I've been a lifelong member of the Academy. I've held leadership roles even ran for the president of the Academy and lost.
Not successfully, I might add.
Even lost. I said lost, not successfully. But I think my point is that we need to keep writing to them. We have to tell them, what we hear from them is some talking points that ceasefire is a military decision. It's not. It's a humanitarian decision. And for those say what we can do, I always remind, I have this in my office, what Margaret Mead's quote, never doubt what a small group of thoughtful, committed citizens can do in the world. Indeed, it is the only thing that has ever. So we have to keep calling our elected officials.
To the various medical academies, I would say start with the easiest thing. Yes, we all want to get to ceasefire desperately. And however, this is the moment when they need, when the World Health Organization, UNICEF, needs the support of the world community on the polio pause. Get the medical truce that gives them 5+2. They need 7 days to do this rollout, and this is where actual advocacy from the associations is really important. But also you doctors who are on the call, constituents, everyone in the U.S., and we have a world audience on this too. Go to your elected officials. We'll be glad to give some templates. We're going to be focusing on that 7-day requirement. let's make sure that they get what they need, that the medical community in Gaza and the community health workers can do what they're going to do so well. They'll do it with care. We all need the breathing room, but certainly the families in Gaza need that breathing room as this polio vaccine is rolled out. May it be the start of the ceasefire we all long to see. But let's get this started. In addition, everyone on the call, support is something that is appreciated. Financial support. We've got MedGlobal. They're doing clinics, they're providing nutrition. One nice thing that came out of last week's call, and nice is an understatement, was just the people on the call connected with MedGlobal to get nutrition supplies to ailing children, the ones that are now in malnutrition and in very serious malnutrition. And that's a large population, but there are, of course, cases that are extreme risk. Go ahead and open your wallet to be able to support MedGlobal. Rebuilding Alliance, every time they announce the evacuation, we're moving our kitchens, but it's the kitchen, the families who are serving, the extended family, because they're not going to leave their grandmother behind. We're scrambling to find them space. We have a compound that takes in as best we can, but it's not enough. And the cost and the reestablishment of getting the food back up and serving, like you take a kitchen out from a location, you're going to let everyone starve? Like what's going on with this? But it does have cost. It does mean it needs to be addressed. Your donations do matter for all of the organizations that are providing aid and support. And we are getting it is possible, like we continue to actually serve food. It really is happening. We are able to transfer funds, all of that nitty-gritty detail. Anyone needs to know about it, we're happy to provide descriptions and details on how that works. In terms of Congress, I do believe there's a role, and a very important role. Congress has established its friendship with Israel and is acting to be supportive in every possible way. This affects everyone. It affects unvaccinated or undervaccinated communities in every country, including in Israel. They know the risk is there because the soldiers are already being vaccinated. They were from the moment that the virus was found back in June. So we know that the army is taking it seriously. The society is taking it seriously. We want Congress to reach out and use their friendship now. Everyone who stood up when the Prime Minister of Israel came to speak in the United States, this is the time for them to make calls on your behalf as constituents. Ask our Congress, office by office, to bring forward the polio pause. Ask them to help get the 7 days that are needed, and ask them to extend it beyond that. We've seen time and time again, Carter Center has been helpful in negotiating days of tranquility or these humanitarian pauses, and they, in their experience, and now in Mali in particular, they've been able to extend it beyond a few days, beyond a few months, 2 years. Like this can be the opening. And so using that, bringing that good energy forward, because it saves the world, like let's get this, to Congress so they fully understand and can represent us with the relationships that they hold. That's very important. And that's they don't have to be loud about it, but they can. This is the time when everyone should be quite loud and certainly bring this forward in support of all the good work of WHO and UNICEF and all of who will be involved in the rollout of the vaccine, if only we can get there.
Dr. Akbar, do you want to have a comment on this?
No, I think my senior colleagues have said it all. I just would say that probably we all need to speak with one voice and raise this to the level that we can. and to actually finish this job, as probably Dr. Mobeen said, it's more than 2 decades now that we are fighting this polio. And if this situation continues, so we'll still be fighting it maybe some years from now. So I think all of us need to raise their voice wherever we can and whatever we can. So if we raise it together, I think we can make a difference. Not to add anything more, I think much is being said already. Thank you.
Great. I just want to add one last piece. And for those of you who are in the US, a few 2 weeks ago, we put out a call to ask those of you who are pediatricians to go to your children's hospitals to urge them to accept children from Gaza. Unfortunately, we have a handful, but I would have anticipated we would have dozens of responses. And so now's the time really to engage all of the assets and resources, the linkages, the political, the social capital that you have, really to focus now on this issue. And as I mentioned at the beginning, you know, the million children in Sudan and other places that really we have a responsibility to address as pediatricians and as pediatric organizations. I'm going to turn this back over to Donna. Again, this has been a great opportunity, Dr. Akbar. Thank you for taking the time and to be with us and give us your insights. John, thank you so much for all the tremendous work you're doing with MedGlobal. And hopefully we'll be able to collaborate with you in the future. And as shameless advertisement, again, please join ISSOP. Go to issop.org. Join us. The membership is free. And we need your knowledge and expertise and passion. And let me turn this over to Donna. And again, thank everybody for your involvement.
Thank you very much, everyone who's been on the call, and to you, Dr. Mobeen, and to you, Dr. Jeff, for adding to the picture of our understanding of this such serious issue. We welcome everyone to, we'll be sending out another template. Actually, if member of our team, if you can post to the list how they can reach to Congress. We do have a template now, and we'll be updating it with what we've learned from this briefing as well. Thank you again for everyone who's been on the call. Nisreen, would you like a closing remark about the advocacy efforts and what might be happening next, and also about our next webinar?
Sure. So this is going to be a weekly series, so we hope to see you next week at the same time. And in terms of advocacy efforts, we are hoping that with all of your help, we can continue to put pressure on policymakers in order to achieve this polio pause, and in order to make sure that there really is the conditions for all of these necessary things to take place. Emailing your reps and scheduling meetings with them is always good. I am pulling up the link right now. And if you all subscribe to our emails, we can also continue to let you know every time we have a meeting with your reps in particular.